A lot of this will probably be flashbacks to residency, but uh, it's interesting to note the progression of our residents as they read chest radiographs. They start out as first years and are very intimidated by the chest radiograph, and probably rightly so. Then they get a little more comfortable and they start focusing on cross-sectional imaging. Their answer is next up in management on a chest x-ray is always a CT. They want to see more. And then they start taking call, and then they probably get a little too cocky with their chest radiograph interpretation. By the time they're more senior residents, they're starting to realize, I'm going to be reading these independently soon, and their confidence level starts to go down again. And even as attendings, I think our confidence can wax and wane. But fundamentally, chest radiograph interpretation comes down to anatomy and an appreciation of the technique associated with it and what the limitations are. We've seen some excellent examples today of chest radiographs and some of the subtle findings on radiographs that really kind of make radiologists who we are. So I want to start off just by talking a little bit about, well, what do we mean when we talk about line stripes and interfaces? Well, these are basically formed by the relationships of anatomy in the lung mediastinum and pleura. And they do have different meanings, and we'll talk about them. But really having a very strong knowledge of anatomy is going to be crucial when you're looking at chest radiograph, because it's that knowledge of anatomy that can really help you detect subtle disease in its earliest stage. And abnormal findings of line stripes and interfaces will manifest as thickening of these line stripes or interfaces, displacement, or obliteration. And probably the last item, the obliteration, can be challenging because, as the old saying goes, it's hard to see what isn't there. And so you really have to be familiar with what should be there. Now, as I mentioned, these line stripes and interfaces, it gets down to densities. And so generally in radiographs, we talk about 5 densities, although there's really a million shades of gray, which, as I joke, is probably a really bad book. But you've got air, fat, water, bone, and metal. As I work with our residents or students, I always kind of tell them, all right, I need you to tell me which of the 5 this structure is, and trying to help them stick it. There's also the concept of the silhouette sign. And so if you have objects of similar density that are next to each other, when you take your radiograph, you're going to have a similar appearance on the resultant film or image, and you're going to lose the interface. And so there's no silhouette. This has started to be called the interface sign rather than the silhouette sign, but it kind of gets to the old school. I still use the term silhouette. Whereas if you have objects of different density and they're next to each other, the more dense structure will attenuate the x-rays more, and it will preserve the density as well as preserve the interface. And so then you can see that, hey, even though they're next to each other, the interface is preserved. And we use that to our advantage. I also want to talk a little bit about the concept of lateral inhibition. So why do we even see these lines and stripes and interfaces? Well, we have 2 different types of photon receptors or photoreceptors. We have light, and so when you have an image with bright in it, it activates those light receptors. And we have dark photoreceptors that are activated when we see something very dark. Now, that's very good and well, but the issue becomes when you have a mixture of these. So when you have light and dark together, that border where they start to kind of come close together, it can be a bit fuzzy. And it introduces this concept of what's called lateral inhibition. So they start to compete with each other. And fortunately, there's another thing that happens, which is edge enhancement. So this is all done in our neurosystem and brain. And it takes that interface that is kind of fuzzy, and it forms a more distinct margin. So we get edge enhancement associated with our visual system as we're looking at these images. So that results in 2 phenomena. One is contrast misperception. And so we may actually perceive something that isn't really there, or differences, I should say, in contrast. And then the other is mock bands, where we actually will see a line which actually isn't really there. And so let's talk about contrast misperception. So you've probably seen some of these visual kind of, they call them illusions, but they're not necessarily illusions. But as we look at kind of those gray rectangles, the ones that are kind of against the white background versus the one against the black background, when we look at those gray boxes, the boxes on the left, they look darker than the boxes on the right. But that is due to lateral inhibition, and it results in contrast misperception. So if we were to actually bring these together, we can, and I'm not doing anything fancy here, right? These are actually all the same color, but they look different based upon the background. And then there's the concept of mock bands. And again, this is, we're seeing something that's not there. So it'll form a line based upon the background and what's going on. And so quote unquote positive mock bands will appear as bright lines and negative mock bands will appear as dark lines. And this is an example of mock bands. And so we have these columns here of different shades of gray, and right at those interfaces where we change from one to the other, it almost gives a perception that on the left of that interface, it's slightly brighter, and on the right, it's slightly darker. And if we actually kind of get rid of the interface to some extent, you can see that that phenomena goes away. And this is an old image that, again, illustrates that phenomena. So a positive mock band shows up as being bright. Oops, I got my arrows reversed. That's the negative mock band. There's the positive mock band on the left and negative mock band on the right, just running down the middle of those images. So now with that background, let's talk about lines. So what are lines? Lines are formed by two air-filled structures being next to each other. And it's the interface between them that forms a line. So normally lines are less than 2 millimeters in thickness. And what are some examples? Well, we're going to talk about the anterior junction line and the posterior junction line in the chest. And some of these radiographs are older, but I think they still highlight the relevant anatomy here. And so the anterior junction line is formed basically by the two lungs, left and right lung, where they meet together anteriorly. And that line is formed by the parietal pleura, the visceral pleura, and some of the intervening fat in the mediastinum. And on chest radiograph, at least the literature says that we can pick it up about 30% of the time. You'll see it there as highlighted by these arrows. From a location standpoint, it's going to occur below the level of the clavicles. And I'm going to zoom this up a little bit. You can kind of see where those junctions are for the anterior junction line, where they kind of meet for the right and left lung. It's a lot easier to appreciate this on CT. Here's a patient with some emphysema, so the lungs are even more expanded, but that line there, that is our anterior junction line. And so why is it important? Well, I'm going to show you another example. Here we have the anterior junction line. It's a little bit more thickened. And what can happen here is we can have abnormalities of the anterior junction line. So as I mentioned, these line stripes and interfaces will either be thickened, displaced, or obliterated. In the setting of cancer in the chest with the anterior junction line, neoplasm can do any of those things. Lipomatosis tends to thicken or displace the anterior junction line, whereas lymphadenopathy, hyperinflation, and volume loss, I think postoperative changes, will displace the anterior junction line, if you can even see it. Again, it's usually only picked up about 30% of the time. Now here's a patient, postoperatively, they've had right lung resection or partial resection, and that anterior junction line is shifted to the right. And in fact, it kind of just looks like scarring on the chest radiograph, but on the CT, we can see, in fact, like that is the anterior junction line. It is displaced and thickened as a result of post-surgical changes. This patient was post-middle lobectomy. What about the posterior junction line? So again, lines are basically 2 millimeters or less in thickness. And in this particular case, it's going to occur, we're going to see it above the level of the carina, usually in the region of the clavicles or slightly higher, extending above the clavicles. And it's even less frequently present on chest radiographs. From time to time, it'll kind of catch my eye and I'll be like, oh, what is that? And it's like, oh yeah, that's the posterior junction line. I kind of forgot about that because we don't really see it all that often. So again, on a radiograph, this is where that posterior junction line occurs, and it's much more subtle, perhaps, than the anterior junction line, but it extends above the clavicle. This is the anatomic location on the CT. Again, it's where the right and left lung just come in contact with each other posteriorly. So as I mentioned, these are some of the pathologies that will either thicken, displace, or obliterate. Again, so you think of mediastinal masses, neoplasm is doing any of the above, but lymphadenopathy, aortic disease, volume loss, hyperinflation, they tend to just displace. So I don't have a lot of examples of anterior posterior junction line pathology, so we're going to move on to stripes. So again, line stripes and interfaces, sometimes we tend to use these interchangeably, but there are radiographic definitions of these. So what is a stripe? Well, stripe is also outlined by air-filled structures, so adjacent air-filled structures, but it's going to be thicker than a line. So it's now 2 to 5 millimeters in size as far as the thickness. And so what are some examples of stripes? Well, we've got our right or left paratracheal stripe, the posterior tracheal stripe, also called the tracheoesophageal stripe or interface. And I use that interface versus stripe, and you'll see here in a minute. But posterior wall of the bronchus intermedius is technically a stripe as well. And so let's talk about some of these. So the right paratracheal stripe, it's basically the visceral and parietal pleura, which touches the lateral wall of the trachea. So you have air in the trachea, you have air in the lung, and the interface between them, it's more than 2 millimeters, it's going to be a stripe. And again, the right paratracheal stripe is usually about 4 millimeters in size or thickness, and we see this on most radiographs, 95% of the time. Here it is again on a chest radiograph. We can remove that line. You can appreciate the appearance of it. And here it is on CT. So on CT, it's that area between the air within the trachea and the lung. And essentially, it's the wall of the trachea. Now, sometimes things can intervene or make the wall thickened or kind of track along the wall of the trachea, which on the radiograph will result in thickening of the paratracheal stripe. Well, what are some pathology that we can see in this area? Well, again, you can have direct primary thickening of the tracheal wall, and that could be due to neoplastic involvement. You can have thyroid that tracks along the wall, or even parathyroid, which will result in thickening. The pleural space, again, it's formed by the interface with the pleura, so you could have pathology involving the pleura that will result in thickening. Lymph nodes, particularly paratracheal lymph nodes, can result in pathology or other mediastinal disease processes. So this is a bit of an older radiograph, but it really shows this large mass. And technically, this is widening of the paratracheal stripe. It's obviously more than just the paratracheal region, but that normal line with aerated lung and the trachea, we don't see it. It's been obliterated and in this case, really, really widened. And so what does that do to? Well, here our residents would be right. You can give a differential, but now you want a CT. And so you want to take a look and see, well, where is this exactly and what is causing it? And what you can see here is kind of, again, the wall of the trachea is no longer next to aerated lung. Instead, we have a soft tissue mass, and that is forming the widening of the paratracheal stripe that we see on the radiograph. And this was actually due to a parathyroid adenoma, is the final diagnosis here. Here we have another one. So again, we have this area. It's a soft tissue abnormality. Portions of the paratracheal stripe are not well defined. And so on the CT, this is what it looks like. So again, you can see anteriorly, we actually have a little bit of the, there's my mouse, it's a tiny mouse. But we can see this portion here of the tracheal wall, it's aerated lung and the trachea, but most of that paratracheal stripe is opacified by an abnormality, which in this case turned out to represent lung cancer. So we definitely want to pay attention to our paratracheal stripes. Here's another one. So prior cases, we showed thickening of the paratracheal stripe. In this case, it's not only thickened, but it's also displaced. And here's the corresponding CT. This is just a huge multinodular goiter that's resulting in loss of the paratracheal stripe and displacement. What about on the left? So much like on the right, It's formed by aerated lung and air in the trachea. The primary difference is that the size here is much more variable, but it's going to be more than 4 millimeters, which is what we expect on the right. In fact, we can allow up to 15 millimeters in thickness on the left, and that's just due to anatomy. And so we'll see some examples. And the left paratracheal stripe is not as commonly clearly visualized as it is on the right. So here it is. That's where the paratracheal stripe or interface should be. Sometimes, again, in this case, you can actually see the distinct stripe separate from the other mediastinal structures, but sometimes they're kind of contiguous and you get thickening of that area. So let's take a look on CT. This is the area of the paratracheal stripe on the left. And so it's not just a thin kind of the wall of the trachea, but here we've got much more mediastinal tissue, including some vessels that contribute to widening of the paratracheal stripe on the left. So what about pathology of the left paratracheal stripe? So very similar to the kind of differential considerations as we saw on the right, but in this particular case, we're going to include more vascular considerations, particularly of the arch vessels tracking along the left paratracheal region. So here we have a case where, again, we can see the air in the trachea, but we don't see the stripe. Instead, we have this thickened area denoted by that yellow dotted line before we actually get to an interface. And this is thickening of the left paratracheal stripe. And what does it look like on CT? Well, here, not only is there some thickening around the trachea itself, but there's also a discrete soft tissue mass. And this turned out to be a case of metastatic thyroid cancer. So it was locally or regionally metastatic, but this was due to metastatic thyroid cancer tracking along the left paratracheal region. In addition to left and right paratracheal stripes, we have the posterior tracheal stripe. And so we see this on the lateral radiograph. And we can see this on, if the patient's well positioned, you should almost always see it. So the literature says 99% of the time. I think they wanted to allow some flexibility because you can't always say 100%. But I feel like we see this almost on every single lateral chest radiograph. And this is formed by air within the trachea adjacent to air within the esophagus. And sometimes, or sorry, in the right lung, not the esophagus. I'll talk about that in a second. But the right lung and air in the trachea is the posterior tracheal stripe. And then where it contacts the esophagus, that is called the tracheoesophageal stripe. So a little nuance there. But it tends to be about 5 millimeters or less in thickness, and we see it frequently. So here it is. This is an important boundary with the radar triangle, so called the danger zone that they talk about on the radiograph. But that is the anterior margin of the retrotracheal space on the lateral radiograph. Here it is on CT. So it's the posterior aspect of the tracheal wall adjacent to aerated lung in the right lung. And so it's contiguous with the right paratracheal stripe, but once it goes posterior, it becomes a posterior tracheal stripe. All right, and these are just different patients, again, showing that we can see that on our lateral chest radiographs. Now, the posterior tracheal stripe, again, there are some abnormalities associated with it. So you can have an aberrant right subclavian artery, which is going to be posterior, again, to the posterior tracheal stripe. It'll show up more posteriorly. Then we have, let's see, the so-called pulmonary sling, which crosses between the trachea and the esophagus on the lateral radiograph, forming abnormalities. And then you can also have aortic aneurysms or pseudoaneurysms, which will result in either displacement or obliteration of the posterior tracheal stripe. In addition to vascular pathology, there's also tracheal wall pathology that can occur. So the tracheal wall posteriorly can be thickened in the setting of edema, tumor, granulomatous polyangiitis, or other diseases that involve the airways, amyloidosis, etc. And then you can have esophageal wall thickening. So again, the esophagus is right in that area of the posterior tracheal stripe or the tracheoesophageal stripe. And primary esophageal malignancy can do that, or inflammatory processes of the esophagus, as well as achalasia. So I'm going to show some examples. So here we have thickening of the posterior tracheal stripe. It's more than the 4 millimeters there. And here's the corresponding CT. So that particular area denoted by yellow, that's the interface between the trachea and the what is a dilated esophagus that's been pulled up by the white arrow. And this was a patient with achalasia. And so certain segments of the trachea, it was thickened due to the dilated esophagus that we see on the lateral radiograph. Here we have another one where we've got kind of indentations of the airway of the trachea, resulting in thickening, even though it's very focal, of the posterior tracheal stripe. And what does that look like on CT? In this particular case, again, it's a slightly older case, but we've got thickening due to the adjacent esophageal wall, which is technically thickening of the tracheoesophageal stripe, and it's obliterating the posterior tracheal stripe. Now, the bronchus intermedius can also be seen on the lateral radiograph, and in and of itself, it's an anatomic structure, but it does form a line or a stripe, depending on how thick it is, on the lateral radiograph. And this is formed by aerated lung in the azygoesophageal recess and the airway of the bronchus intermedius. And on lateral radiographs, what we see is that the bronchus intermedius, the posterior wall of it, will bisect the left upper lobe bronchus, which is more en face. And I have some other images here. So let's kind of remove that. And you can see a very delineated line or stripes, depending on how thick it is, here formed by the posterior wall of the bronchus intermedius, again, kind of bisecting the left upper lobe bronchus on the lateral radiograph. Now, we only see it perfectly positioned on the lateral radiograph or perfectly bisecting if the patient is well positioned. Even a slight degree of rotation will displace that line either forward or posteriorly, which makes it less visualized on the lateral radiograph. And so what does that look like? Well, here we have on the CT the posterior wall, the bronchus intermedius in red, and it is not bisecting, but it is what we see as that line or stripe on the lateral radiograph. And it's formed by air in the bronchus intermedius and the right lung. Here's an example. So we've got the left upper lobe bronchus, the bronchus intermedius, and we're going to go ahead and superimpose them. And that's what we get on CT images, which is the correlate of the radiograph. So abnormalities, so pulmonary edema, neoplasm, lymphadenopathy, and there are some other conditions that will result in airway abnormality beyond those. But anything that's going to result in thickening of your central airways can result in thickening of the bronchus intermedius. Here's another case. So this is patients not well positioned, but this is actually the bronchus intermedius. It's too low to be the posterior tracheal wall, but this was a patient that had pulmonary edema that was resulting in thickening. So our last category are interfaces. So this is basically just a boundary between objects of different density. So with lines and stripes, you have two air-filled structures, and where they meet forms either a line or an interface, depending on how thick it is. A line or a stripe. You can see how confusing this is. Whereas an interface is just objects of different density next to each other. And as I mentioned, depending upon the location or the density, you can have the illusion of a line or a stripe being formed. And so some common interfaces are the periaortic interface, the paraspinal interfaces, the AP reflection, the azygoesophageal recess, AP window, etc. And we'll talk about some of these. Again, positive versus negative mock bands to keep in mind. So let's start with the left periaortic interface. So we can see this in most frontal chest radiographs, and you get This interface is formed by the descending aorta and the adjacent aerated lung. And this is what it looks like on radiographs. It's usually pretty well defined. Here we have a different patient where it's a little bit more tortuous, but that's still within normal limits. So there's some variability in its appearance. The left periaortic interface, some pathology are, well, we want to think of things intrinsic to the aorta, such as aneurysm, dissection, coarc, or right-sided arch. Extrinsically, it can be pushed to one side or the other, depending on the presence of a mediastinal mass. Now, this one's showing up as a bit bright, but it's a little bit hard to follow here. But here is the interface. This is perhaps a little subtle on the radiograph, but this was a patient with coarctation that was resulting in abnormality. There's a little bit of rib notching. Not the greatest case, but this was a patient with aortic coarctation, resulting in an abnormal contour of the left periaortic interface. Here we have another patient, and the abnormality here is on the right. And this was a patient that had a right-sided aortic arch, kind of descending down, resulting in kind of displacement or widening of the right periaortic interface, which we usually don't see well at all if the patient has a left-sided aorta. Here's another one with a very large and tortuous left-sided periaortic interface, and a bit more than what we'd like to see. And this prompted a CT, which we can see here. And on reconstructed images, we see the correlate with the radiograph. This was a patient that had aortic dissection. The AP interface is formed by aerated lung and pleura against the lateral main pulmonary artery. And it can be fairly variable. We don't always see it. This is what it looks like on one example here. We often talk about displacement of the AP window, but here we have, again, that interface right along the pulmonary artery extending into the anterior mediastinal fat. And if you get mediastinal masses or lymph nodes, this can become displaced. So let's take a look here. So this patient has a widened superior mediastinum, but of note, there's also displacement of the AP interface. And this turned out to be a case or result from lymph nodes in a patient that had a diagnosis of lymphoma. The AP window is another area that we look at, and it's a complex anatomic space with lots of different boundaries that I have listed out here. But what we're looking for is an abnormal soft tissue opacity in that area. And so that could be due to primarily level 5 subaortic lymph nodes that will displace it. But there's lots of other pathology that can result in abnormalities involving the AP window, as I have listed here. Here we have a rather large, not so subtle mass that's resulting in filling and displacement of the AP window. And on CT, we can see it here. This was just a large primary lung cancer that had AP window involvement. Here's another one with filling of the AP window, but obviously there's hilar as well as paratracheal mediastinal adenopathy as well, classic case of sarcoidosis. And here's another one just on CT showing the AP window with a large centrally necrotic lesion. This turned out to be a case of metastatic breast cancer, but I like this case because it really highlights the anatomy of the AP region. Paraspinal interface on the right. So again, usually there's just a thin amount of tissue that lines the spine before you get into aerated lung. And this is what it looks like on the right. And it looks similarly on the left as well, except the left tends to be a little bit thicker. So in the interest of time, again, the differentials are listed in the presentation, but I want to show some cases. So here we have an abnormal thickening of that right paraspinal interface. There's a fracture of the transverse process. And so this was a paraspinal hematoma resulting in abnormal thickening. On the left, again, it's present. We can see it here separate from the left periaortic interface. And it often results, it looks like there's a positive mock band or a bright line. There it is on CT. Lots of things that can cause displacement. Here we have bilateral widening of the paramediastinal interfaces. And the finding on CT, it was due to extramedullary hematopoiesis, resulting in widening of both soft tissue and ribs. Let's talk about the azygoesophageal recess as I think our last interface. So this is due to aerated lung on the right, as well as air in the esophagus. And we don't always see it, but if we want to, if we suspect that there's pathology there, having comparisons are very, very helpful because we may not always see it. This is where the azygoesophageal recess is located. This is what it looks like on CT. So it's the interface with just air in the lung and then the mediastinum. And you can have air in the esophagus as well that will form a stripe. But here we see on CT, again, where it corresponds to. Lots of pathology can occur in the azygoesophageal recess, but we're going to focus on a few examples here. So here we have an abnormal convexity in the azygoesophageal recess. This is what it looks like on CT. This actually turned out to be a neurofibroma. Wasn't particularly the first thing on my differential, but that's what this pathology was. But again, it's present on the radiograph. Here we have a baseline image and 1 year later. So what's the difference here? Well, the difference is we could see the azygoesophageal recess, and on the follow-up, it's really been obliterated. We don't see it as well. And so in addition to that, there's more soft tissue density in that area. Here's the CT, again, the line for the azygoesophageal recess with the associated soft tissue mass noted by the arrow. This patient went on to get a PET. You can see it's fairly extensive. And this was a non-small cell lung cancer that was really kind of hiding out in the azygoesophageal recess. All right, so this has been a whirlwind review of line stripes and interfaces. They are different. They're somewhat academic. The important thing is that you're aware of the anatomy and that you can then identify when something is thickened, displaced, or obliterated. And chest x-ray is often the first sign of pathology. So chest x-rays are complicated, but having this knowledge of the anatomy as well as some of these line stripes and interfaces can be very helpful and make a difference in patient care. With that, I'm going to thank you for your time.